Okay. Good evening, ladies and gentlemen. We are glad to welcome you all to SciEcho virtual workshop. Before we jump to the session, I'll take you to a quick brief of our outstanding speaker, Dr. Abbas and to refresh your mind with this workshop instructions. Dr. Abbas holds a PhD in medicine and health science. He is academician, assistant professor, research center director, and IRB chairman at Dr. Sulaiman Al-Habib Hospital. He dedicated himself to his area of interest, which is the field of research. Regarding to our instructions, during the session, the discussion and the questions session, you can answer the questions through the chat box in Zoom only. A Google form will be provided after the virtual workshop regarding the certification of attendance. You are required to provide us with your full name in English and your personal email. Some institutions prevent any external domains emails. Thank you, Dr. Abbas, for giving us this opportunity to establish this workshop tonight.
Thank you very much. Thank you, Ad. Thanks for the SciEcho for this opportunity. I'd like to welcome the attendees for showing interest. I'd like to thank them for showing interest to attend the seminar, which is going to be about data management and analysis for epidemiological studies. Well, so all right. It's one part, or it's one of the most important parts of research is data collection and management of data, which will direct the results the overall results of the research. And one of the most major lacks of research is data collection. I've come across many studies where they collect, data mistakenly, and they don't collect a comprehensive data, or they did not examine the data quality that is to be collected. So they end up having a very bad, let me say, data, and then a very bad research outcomes and research outputs. So first of all, this is Dr. Abbas AlMutair. I'm the research center director at Dr. Sulaiman Al-Habib Medical Group, and I'm the chairman of the IRB. I adjunct assistant professor with Wollongong University in Australia, and I'm the founder and the editor-in-chief of the Saudi Critical Care Journal, which is the official publication of the Saudi Critical Care Society. And I'm also editor at Dr. Sulaiman Al-Habib Medical Journal, which is the official publication of Dr. Sulaiman Al-Habib Medical Group. The Saudi Critical Care Journal covers the Saudi critical care, the critical care medicine, nursing, nutrition, anything related to critical care, pharmacy, respiratory. So we accept articles, original research articles, review articles, short reports, and clinical articles, expert opinion piece, debate, and case study letters. Well, overall, the seminar, I'll try to cover the following. I'll identify the major types of data collection methods. We will perform together a data collection plan. I'll discuss the observational data collection methods, or the different types of data collection methods, and then we will identify the different types of data variables and perform data management, how to perform data management, how to perform data coding, data entry, and then data cleaning. And after that, we will cover the data, the descriptive versus inferential statistics, and the commonly used bivariate statistical test and multivariate statistical test. As I've mentioned earlier, it's a major, there are a different, I'll try, and in terms of the data collection methods, I'll identify the major types of data collection methods, perform a data collection plan, compare different types of self-reports, discuss observational methods, and differentiate between validity and reliability, and how to reach to a valid and reliable data collection tool. I mean, does the data collection tool measure what it's supposed to measure? Does it match the research objectives and aims? This is a very, very important. And the validity and the reliability of the data collection. Well, data collection is, all right, so data collection is a term used to describe the process of preparing, and collecting data for a particular purpose from previous sources that has been systematically observed, recorded, and organized. So data collection in general involves a systematic observation, systematic recording, and organization of the data. And data collection usually includes quantitative data and qualitative data as well. So in terms of quantitative data, for example, numbers, and qualitative data might be images, words, figures, facts, or ideas. And data is one of the most important and vital aspects of any research study. And it's one of the major aspects of the research. I mean, the research steps. Research is a systematic inquiry where you have to go through the steps one by one until you reach to a data collection. But for epidemiological studies, for example, you have to prepare the data collection tools, and you have to plan for the data collection at the time of preparing the proposal, at the time of preparing the study proposal or the overall project of the study. So you have to prepare the data collection tool based on the aim of the study, the objectives, the expected outcomes, and the study plan, are what we call it, the design of the study. So a basic decision is used whether to collect a new data or existing data. Are you going to collect a new data for your study, or you're going to go back, for example, to the patient records or historical data or existing data that's already have been published, and so you would like to use that published data and collect it and then use it for your study. Like, for example, systematic review or meta-analysis, records, for example, observational, whether retrospective or prospective studies, as well as the historical study, or you would like to collect a new data for, any prospective studies. So you have to make the decision before you go and you collect your data. So the dimensions of data collection approach, the data collection has to be structured. Talking about quantitative studies. So research data for quantitative studies are often collected according to a structured plan. So you have to have a structured plan that indicates the information to be gathered and how to gather it. Whether you're going to go back to the records of the patients, for example, and you will collect it, or you've got a data collection sheet, for example, a survey, all right, a reliable, a valid survey that has already been validated elsewhere, and you want to use that one. So it's a structure, first of all, and a quantifiability, quantification of the data. So that data that will be subjected to statistical analysis must be gathered in a such way that they can be quantified. So that's why I always recommend to take your data collection sheet to a biostatistician or one who understands statistics. So they look at them, they will see them in a different way where they will try to make sure that it's researchable. They can like apply tests on them. You know, the type of the data that's going to be collected. Is it qualitative? Is it quantitative? Is it numerical? Is it categorical data that you're going to collect? And what relationship that you would like to study in order to make sure that you collect the right data. Researcher obtrusiveness or data collection methods differs in the degree to which people are aware of their status as participants. This is applied to all to qualitative data. Qualitative data differ in the way the researcher collects them. If I'll collect the data, I'll collect it to differently from Wa'ad, for example, or from Muhammad, or from Hassan, or whoever. All right, because we are different persons, so we collect different data, though we have different, the same research questions, or the same like a protocol, data collection protocol. Objectivity refers to the degree to which two independent researchers can arrive at a similar scores or make a similar observation regarding the concepts. And this is applied to quantitative and to qualitative data as well. So, and this is what we call a trustworthiness or objectivity, where we have to reach to a degree where the scores are similar. The observations regarding the concepts are similar between two independent researchers. So first of all, one of the main concepts of data is we have to have, first of all, a research question. Research in general is a systematic inquiry where we have to go through, it's a step one by one, starting from a research problem. Then if you have a research problem, you have to go back to the literature and read in order to find the gap in the literature. Based on the gap in the literature, you will ask a question. And based on the research question, then you will identify your research objectives. The primary and the secondary research objectives, the expected outcomes of your research. And then based on the objectives, you will identify your research plan, whether for example, you're going to use a quantitative or a qualitative research plan, or you will, and what design, whether your approach is quantitative or qualitative, and what design. Is it observational study? Is it clinical trial, for example? Is it retrospective or prospective, and so on? And whether if it is qualitative, for example, any type of traditions of qualitative studies. So clinicians may want to answer questions regarding the relative qualities of competing treatment procedure, for example, or we begin to search for suitable data for our investigation. So such data are usually available for one or more different sources. From one or different sources, either primary sources or secondary sources or existing data already available online. So based on the research question and the research hypothesis and the objectives of the research, we will be able to identify our required data to answer the research question. And this will take us also to what we call the data quality, which is a very, very important aspect in statistics and in a data collection. So we have collected data. Does that data measure what's supposed to measure? Does it reflect the research question and the research hypothesis and the research objectives and aims, or no? This is very, very important. So, and the raw material of statistics is data. For our purposes, we may define data as numbers. For a quantitative study, for example, we may define our data as numbers. That's why we have to code it. all right? Even qualitative, I mean, data, we have to code it into number. So there are two kinds of numbers that we use in statistics are, in statistics are numbers that results from taking, like, for example, measurement, and those that results from the process of counting. Whether we measure those data, we collect them through measurement, like blood pressure, systolic, diastolic blood pressure, pulse, or the process of counting, like, for example, age or gender, and so on. So when a nurse, for example, weighs a patient, the weight of the patients, that's a data or a data. It takes and takes also the patient temperature, that's data. Or a measurement consisting of a number such as 150 pounds or 100 degrees Fahrenheit when they are obtained. All right, and this is a different type of number obtained when a hospital administrator, for example, counts the number of the patients, like the number of visitors or the number of the patients who visited the pediatric clinic, for example, or the number of patients have been discharged from the hospitals. So that's a count. And the measurement, what we usually measure, for example, weight of the patient, temperature, vital signs, and so on. So you may ask yourself, where can we get data from? Well, there are different sources of data. Talking about epidemiological studies, for example. So there might be primary data collection, like we collect data specifically for a project considered, considered primary, like our observation or survey or experiments that we conduct in order to collect a data for a particular objective. Or it might be a secondary, like a data compilation, like the existing record of the patients, pre-existing and pre-calculated data. Like this is called a secondary, like vital records, birth, death, incident reports, medical records, for example. These all called a secondary data sources, while the primary is our observation as a researchers. Our measurement, or using a survey for a particular study or experiments that we conducted for a specific an epidemiological study. Well, I think well, for the sources of data, for example, talking about the first type, which is the routinely kept records. Hospital records, for example, contain a vast amounts of information of patients. For example, gender of the patient, age of the patients, the major complaint of the patients, procedures that have already been done for the patients, medications taken by the patient, procedures performed on the patients, lab results, and so on. So those are routinely kept records. And this is our source of, might be one of our primary sources or secondary sources of data for epidemiological study. Or external sources, for example, the data need to answer a question that already exists in the form of published reports, like the systematic review. All right, so the data has already been published, so or the meta-analysis or the literature review as well, any reviews. So the data is already have already been published. So you go back to it, try to compile them, analyze them, and try to answer your research question or the research hypothesis. And then we have our third type of data sources is survey, for example. We may conduct a survey to obtain certain information to answer our research question. And surveys might be close-ended surveys or open-ended surveys. It depends on the study, the study objectives and the research question and hypothesis. So we may develop a survey for our study, or we may use a validated, reliable survey for the study, and then we try to use it for our study. And then also experiments is another type of data collection or data sources. So frequently the data need to answer a question are available only as the results of an experiment. So we have to perform experiments. We may need to extract blood to use urine, for example, or collect urine from the patients, or any type of experiments, and then perform the experiments and try to collect data out of those experiments. Well, let's move towards. So far, we have talked about the sources of the data. What does data collection mean? And then we've got like two types of data: primary and secondary data, and there are different types. Under each major type, like the routinely kept records, the hospital records, and the observations or surveys that we may use for our study. Now, there are major types of data collection methods. There might be self-reports and observations as well, and biophysiologic measurements. Let's talk about them one by one. In a quantitative self-reports or structured reports in a quantitative study, or self-reports can be used in a quantitative and a qualitative studies. For example, if it is open-ended survey, that's considered qualitative. And if it is close-ended survey, forced answer using a scale, that's called closed-ended, quantitative survey. The main concept over here is the structuredness of the self-reports. So data is collected or will be collected with a formal instrument. So there is a formal instrument, structured one, and it might be used as an interview schedule or a questionnaire survey. So questions are pre-specified but asked orally, okay? Or a survey or questionnaire questions pre-specified in are specified in a written form to be self-administered by respondents. Okay, so questions or that's the
Dr.Abbas.
ايوه معك وعد. الو، صوتي واضح؟ صوتي واضح؟ وعد؟
ايوه there is a technical issue قاعد يقطع شوي.
اوكي الحين صوتي اوكي ولا؟
ايوه كذا واضح دكتور.
طيب اوكي
اي واضح الصوت.
اوكي self reports.
اي sorry for the interruption.
All right, that's okay. All right, so self-reports. There are types of quantitative self-reports, which is mainly structured self-reports. It might be close-ended or it might be open-ended. So data are collected with a formal instrument. So we have to have a formal instrument. We collect data through it using either like a survey, a questionnaire, or interview schedule. We may ask questions and the respondent will answer those questions. So we have a protocol, a self-report protocol, and we go through the questions one by one, and the respondent will answer them. That's called a structured self-report. Or we may use it, I mean, it might be self-report, I mean, the answers or the respondents can answer it themselves. So this is the main difference between them. And there are different types of close-ended questions. So questions might be multiple choices questions, Dr.Abbas questions, where respondents are required to make a choice between two responses only, yes, no, male, female, so they have only to choose one of them, or multiple questions over more than two response alternatives. And also we may have a rank order questions, for example. Respondents are asked to assign a 1 to the concept that is most important, and 2 to the concept that's second important, and so on, third important, fourth important, and so on. And we have a forced choice questions. Respondents are asked to choose between two statements that represent their position or characteristics. And we have a rating questions, for example, we ask the respondents to evaluate something along an order dimension. Let's take or go through those scales or have an examples of those scales one by one, which is mainly on the psychosocial science. Scales are used to make a fine quantitative discrimination among people with different attitude, perceptions, or traits, like Likert scale or semantic differential scales. Likert scale, for example, or Likert scale consists of declarative statements where the respondents will choose from the responses whether they agree or disagree with the statement. So the points varies between 3 points to 10 points and the Likert scale. So strongly disagree, for example, represents 1, and the strongly agree represents, 7 represents strongly agree. So the respondents have to choose between the points. So responses to items are summed to compute a total scale score. Later on, we have to compile all, or we collect all data, do the data entry, and then analyze them. Analyze overall the scores and come up with the mean and the standard deviation of each statement, each and every statement. All right, so semantic differential scales require rating of various concepts, for example. Rating scales involve bipolar adjective, pairs with 7-point rating scale, for example. Ratings from each dimension are summed to compute a total score for each concept. And dealing with scales is a nightmare. The analysis of these scales is a nightmare. It has to be validated scale. It has to be well validated and reliable scale. And you have to go through a different process in order to reach to a validated scale. For example, start with the face validity and construct validity and the reliability. We have to check, for example, first of all, we have to prepare the survey. If we would like to develop like a new survey or a scale for any particular study, we have to develop the scale first of all, then maybe review it with an expert panel, and give them the research questions, the research aim, and the hypothesis, and develop the scale. They will have to rate or compare between the scale and the research questions and aims, whether the questions asked in the scale reflect the research aim and objectives. And then after that, if this process completed, we then try it. You know, we try the scale, or we conduct a pilot study of at least 35 participants, and then we apply a statistical test, like, I mean, a reliability test like Cronbach alpha, if it is, I mean, a pilot study. Then if we collected data, we may do what we call the factor analysis, but you have to have at least 400 responses in order to reach to a point where you have to, I mean, you can claim that you have a valid scale. This is an example of semantic, for example, differential scale, you know, competent, incompetent, and the respondent have or has to choose from the numbers indicated in this scale, from 1 to 7 or 1 to 6 or whatsoever. And there is what we call the visual analog, VAS scale as well, you know, used to measure subjective experiences like pain and nausea. So we ask the patient, for example, to rate from the visual analog in order to measure their experiences. So no pain at all, and this is a pain as bad as it could be. Measure are on a straight line measurement, 100 mm, endpoints labeled as extreme limits of sensation, whether no pain or pain as bad as it could be. And then we analyze it. I mean, we analyze the overall score of the, for example, pain or nausea of the participants participated in the study. So it's very important to evaluate the self-reports. You know, strong indirectness, allow access to information otherwise not available to researchers. I mean, using the self-reports are very strong in directions, though they are, I mean, nightmare in dealing with the, survey studies or self-report studies. They allow access to information that are not available to us as researchers. But can we be sure participants actually feel or act the way they say they do? And this is a very, very important, you know, to measure the validity and the reliability of the scale that we would like to use in our study, and make sure, you know, it measure what's supposed to measure. All right. So far we have covered the self-reports. Now we shall move towards, so far we have covered the self-reports, now we shall move towards the observation. Data collection method. Well, observation in qualitative and quantitative studies.
Dr. Abbas?
Yes. أيوة وعد? Yes.
Before jumping to the observation topic, you should double check the connection because we're facing a poor connection from your side.
Okay, I'm so sorry. How is it now?
It's still poor connection.
Hello? Still?
Okay, can you say a long sentence to double check?
Yes, observation. So far we have covered the self-report methods. Now we shall move towards the observational data collection methods.
Yeah, much more better. Thank you.
All right, cool. All right, so observational data collection methods, observational qualitative and quantitative study. Qualitative study as unstructured observation in naturalistic settings. And then we have, it includes the participants' observation and quantitative studies, structured observation of pre-specified behaviors. Now, overall evaluation of the observational methods, it's a very excellent method for capturing many clinical phenomena and behavior. Well, one of the potential problems of reactivity when people are aware that they are being observed. So they may act in a perfect way, so you can't capture the phenomena, and risk of observational biases. And risk of observational biases. لحظة بس خلينا نشوف. Sorry for the ما أدري إذا الصوت في مشكلة ولا.
دكتور عباس.
أيوة. الصوت الآن أوكي ولا بعده؟
Dr. Abbas, can you hear me?
Yes, I can hear you. الصوت أوكي الآن أو بعده؟ Still. ألو؟ الصوت اوكي الان او بعد ستيل؟ طيب لحظه بس لحظه معلش سوري بس I will try to fix it.
Ladies and gentlemen, we're going to have to 5 minutes break to fix this poor connection from Dr. Abbas' side. Please be patient and we'll be back with you for
طيب okay. I don't know if okay. Hello, is it working now?
Can you provide me with a long sentence, doctor?
All right, so an evaluation of observational studies, which is an excellent method for capturing many clinical phenomena and behaviors.
Sounds perfect.
All right,
We just have 1 minute left as I assigned 5 minutes break. Then we can back on the track. Thank you, doctor.
cool, that's okay, thank you.
You may start.
All right, cool. So evaluation. So far, we've talked about the self-reports and the observational methods of data collection. Well, observational methods as an excellent method for capturing many clinical phenomena and behaviors. You know, we capture them as they naturally occur. Though you know there is a potential problem of reactivity when people are aware that they're being observed, so they act in a way that you know it hides or it blocks the phenomena or the observation that we would like to observe. You know, also this we may, you know, take us into a risk of observational biases where factors that can be interfere with objective observation. So reactivity, observational biases, some of the potential problems or disadvantages of observational methods. One of the most important methods of data collection is a biophysiologic measures, which is in vivo measurement. I mean, we divide it into two types: in vivo and in vitro measurements. In vivo performed directly within or on a living organism, like for example blood pressure measurement, pulse measurement, and so on. And in vitro performed outside the organism, like the urine analysis, blood test, lab results, and so on, or the labs of the patients. So this is, you know, the main difference between the in vivo measurements and the in vitro measurements of the biophysiologic measures of data collection methods. Now, I shall, I don't know what time is it right now. All right. So we shall, I'm so happy to take any questions before we move forward and to the next part of the seminar. So the next part will be about data types and the different types of the data. So far, I've covered the data collection methods, the self-reports, the observational reports, and the biophysiologic measurements. If you've got any questions, you can ask it. So we answer it or we discuss them before we move forward to the next part of the presentation or of the seminar, which is the type of the data. You can write your question, or you may raise your hand and I will unmute you to ask your question. All right, so Sheetha, all right. Yes, please. Sheetha or Ben Malik, you can talk. Hello? All right. If you have any question, we can answer, I mean, we can discuss it before we move forward to the second part of the seminar or of the presentation. All right, Ala, okay. Yes, you can talk, yeah, Ala.
Yeah, yes, hello. Thank you for the talk. So I have questions about data collection. So for example, the data collection from the patient records, how is the kind of the data extraction process if we don't want it like manually, only like automatically? Is there like something in the system itself that enable this kind of feature?
Well, it depends on the system itself. If it will, I mean, if you have an health information system, this may allow you to extract the data and use it for research. And if you don't have a health information system, then you will have to do it manually.
So
But,
what is the...
Yeah, I'll answer that one. But though even, I mean, the health information systems available, they are not a research friendly data. Do you know what I mean? Well, we have to manage them. We have to encode them. We have to collect the information or the data that we want for our study. And you know, most of the health information systems that are available are not research friendly data, mainly. But we have to, manage them. I mean, we have to perform a data management in order to collect the information that serves our study. Well, it depends.
Any recommendation of kind of system that is like really user-friendly, like for research and data collection?
No, there is no, I mean, if I understand your question, well, you have a data collection that you would like to perform on a patient's records, right?
Yes.
You would like to extract data for your research from the patient records. And I mean, in the patient records, there is everything. But you will only collect the data that you want for your study. And mainly, they are not research friendly data. I mean, they are not coded data, so you have to code them. You have to collect the data that you need for your study. So this is very, very important. And sometimes health information systems are not available, so you have to do it, manually. We'll try to cover them in the coming slides.
Okay, thank you.
No worries. Abrar, okay. You may talk, ya Abrar.
Hello. Hi.
Hello. Yeah.
Thank you for the presentation. About the scale, how can we measure it in a like very valid way? What test should we use to measure the scale?
Well, first of all, if there is a well-developed scale, then you can use it. I mean, for your study, if it serves your study, then you can use it. You don't have to, I mean, if it is well, tested, reliable, valid scale that has already been used for in different studies in different settings, then you can use that one. First of all, if it is well, reliable, valid scale. Now, if you have to develop your own scale, then first of all, you have to develop your research proposal, your research objectives, research questions, and then based on the research objectives and proposal, and questions and hypotheses as well, you will develop your scale. Then if you have developed your scale, then you will first of all need to review it with an expert from the field. Say, for example, the studies about, let me say,
gestational diabetes.
let me say critical care, okay? So you need to take it to an expert in this field, like academicians in the critical care and clinical, clinicians in the clinical care, like doctors, intensivists, nurses, and so on. So they have to review it. They will read, you will give them the study objectives and the research questions and the scale, and they will compare and they will rate, all right? Whether, the questions that you have asked in the scale reflect the study objectives and the aim and the purpose of the study and the research questions. After that, this is one process. The second, after that, next to this this step, you may need to do a pilot study.
Yeah.
All right. So a pilot study of at least 35 participants, and then you perform a reliability test, which is called the Cronbach alpha. And then after that, you will check the Cronbach alpha. The Cronbach alpha is usually between 1 to 0. If it is close to 1, that's an acceptable acceptable range. If it is close, if the items are close to 0, then you have to delete them, and then you will repeat the test again until you reach to an acceptable.
Do you think is it better to avoid like working with scale? Is it more complex to work with scale, comparing, for example, with dichotomous variable?
Yes, dealing with the scale is a nightmare, and it's very, very hard to reach to a valid and reliable scale. That's why I highly recommend, if there is a scale, a valid or reliable scale, that just only use it, and that's it. Do not develop your own scale, because it's very, very hard to reach to a reliable and valid scale. It's not
because
it's very hard.
Because I asked this question because it's very hectic to work with scale in terms of analyses.
That's
and
yes. It's very hectic, and it's nightmare analyzing. I do data analysis, and it's very easy for me to analyze data from clinical studies, observational, retrospective studies, while it's very, very hectic and very difficult to deal with scales. And
so I think we should avoid working with scale unless we had to.
Yeah. Well, it's if my recommendation that if there is a well valid and reliable scale that has already been used elsewhere, just use it. Okay, and and write your justification of using it. Well, another point that I would like to or overview here, the psychometric properties of the scale. For example, if the scale is in English and you want to use it in Arabic, then you have to we have to do what we call it back translation procedure. For example, what's your name? Abrar. Okay.
Yes.
Abrar. All right. Abbas have a scale. I translate it. I'll give Abrar the English version. I would like to translate it into Arabic. I'll ask Abrar to translate it into Arabic. All right. And then Abrar, when she translates the English version into Arabic version, I'll take the Arabic version and give it to, for example, Wa'ad. I'll ask Wa'ad to translate the translated Arabic version into English again. All right.
So I
And
think we
I'll
could.
then take, so I'll have 2 English versions and 1 Arabic. I'll take the translated English and I give it, for example, to Muhammad. Muhammad, I'll ask him to translate it into Arabic. So, and I'll take the 2 versions of Arabic and I'll give them to 1 independent reviewer or examiner, and I'll ask him to compare between the 2 versions. This is how we reach to a valid and reliable. And then after that, we have to test its reliability and validity as well.
Yeah,
you change only 1 word, only 1 word. Okay, for example, you've removed 2, then you have to retest it.
but I think like translating the scale from language to a different language could introduce bias, like language bias.
Well, there is no a certain way or method of a translation, but the most, reliable way of translating documents or research documents is the back translation of procedure, the one which I have already discussed. All right.
Thank you so much.
Yeah. I'll take to Abu Bakr. All right. Please.
Assalamu alaikum, Doctor.
Assalamu rahmatullah.
Regarding the research obtrusiveness, you mentioned that the participants they might be aware or not aware of the status in the research. Will that affect the quality of the collected data?
Yes. There is a term in research called, I forgot the term, Hawthorne concept, something like this, I think. Yeah, I forgot the term. Well, if the participants know that he is being observed, he will act in a perfect way.
Yes.
And this will abstract, the data that we would like to collect.
Yeah,
right? And we would like to collect the data, as the naturally, the phenomenon, we would like to collect the phenomenon as they naturally occur without any interferes. So if the participants know that he's being observed, they will, or he or she will act in a perfect way. And this, we don't want this one in our data.
Okay, thank you.
No worries. Okay, what time is it? All right. So في أحد, okay. The last, I'll take one only. Hanan, okay, I'll allow you to talk. That's the last question. Then we'll have a break and we will continue after that. Okay, Hanan. Yeah, you can talk, ya Hanan. Or who else? Or Rinad, okay, Rinad, yeah. Okay, Rinad, all right. Rinad Al-Harbi.
Assalamu alaikum. Thank you for the great presentation, Dr. Abbas. I have a question. If in my study I use, for example, like 3 validated and published scales, do I have to validate the questionnaire in general? To validate the other questions regarding the demographic data and the general health information and so on, or that's enough?
Well, have you translated those scales, or you use them as they are in English, for example?
No, they are validated in Arabic.
All right, cool. That's good. Now, you don't have to do a validation for the socio-demographic. Validation only for the scales. Okay.
Okay. What if I use diagnostic criteria? I use 2 scales and two validated scales in Arabic, and the third is a diagnostic criteria. But this is like a known diagnostic criteria consisting of 4 items. Should I?
No,
Is it worth it?
No, you don't have to, revalidate it. Is it a scale, the diagnostic criteria, or only a questions?
No, only questions
All right,
that
so
we use frequently.
we have to differentiate between scales and forced answer questions. For example, what's your gender, male, female? What's your age? Where do you work? Okay, do you have this disease, for example? Are you diabetic? Do you have hypertension? So, and we have to differentiate between those types of questions and the scales. All right, so what should be validated is the scale, not the socio-demographic questions or the background, for example, questions.
Okay, thank you so much, Doctor.
No worries. We'll take a break. I think Waad.
تفضل دكتور.
Waad.
Yes, I'm here.
All right. So is it a time for a break, or and then we'll come back, or what?
Let me check. The break, doctor, start 8:30 to 8:45.
Okay, cool. All right. So we will...
You can either accept more questions. We have some questions here in the chat box, or you can complete the presentation.
Sure. I'll Dr. Madri, I'll allow you to talk under my name, Dr. Abbas. You can talk, or...
Doctor?
Yes.
Regarding your question is, do we need to take the patient approval to take the data?
Do we need to take, that's another issue. Do we need to take the
question? I was about to answer that one.
Well, it depends on the study itself. Can you explain about your study so I can make a...
You asked the question and I was about to answer. That was it.
I really didn't get it.
You asked in the chat box. I think that's Dr. Abbas.
That's not me. Somebody else under my name, I think. But anyhow,
you can rename yourself. There is an option. There is a down arrow. You can just rename yourself.
Yeah. First of all, I'll talk about the informed consent. Informed consent, there are two concepts of informed consent. There is what we call it a full self-determination and full disclosure and informed consent. So what does full disclosure mean? So the patient or the participants in the study has to be aware of everything in the study. Okay, this is called a full disclosure of the information that the participant should know. And then the other concept in the informed consent is the self-determination. So the participants has the right to either agree or disagree to participate in the study. This is one. And to withdraw from the study anytime he wants or she wants. Mm-hmm. This is called informed consent. Now, when can we apply informed consent and take the permission from the patient to or the participants to collect data from? That's a different concept or different issue. We have to know what type of study is it. Is it observational study? Is it retrospective, for example? If it is retrospective study that you will go back to the record, so you don't have to take a consent from the patients. Is it a prospective study? Well, if it is a prospective observational study, it depends on the data that you would like to collect. So we have to evaluate them, evaluate the data to be collected, and based on it, we will ask the researcher to whether take a permission or ask the participants to sign a informed consent or not. I wish I answered this.
It's genetic study. How about that?
Sorry, what was it?
Genetics, related to genetics.
Well, will you collect data from the patients?
Yeah.
Blood, for example?
We're going to take a lab test.
So
Genetic.
what lab test? So will you collect data from the patients, right? صح? You will collect data from patients.
Yes.
All right. So I think, yeah. Well, it depends on the study, but I think yes. You know, I have to look at the proposal, but I think yes, you have to take the permission from the patient. All right. So next one is okay. Next, please. Hello. Yes, you can talk.
Yeah, can you hear me?
Yes, I can hear you.
Yes, I can hear you. Yeah, I have a question regarding validated questionnaire. If I had to combine more than one questionnaire, I'm sorry?
I can't hear you very well.
Yeah, can you hear me now?
Yes, okay, go ahead, please.
If I had to combine more than one validated questionnaire, would that be okay, or do I have to revalidate?
So I didn't hear you very well, please.
Can you use parts of validated questionnaires, or does it have to be
validated? So you have changed something in the scale.
It's not, yeah, not the scale, the questions. No, not the scale.
Is it a scale?
It contains a scale, but I'm not changing the scale.
So you will take the scale, however, you will only change the socio-demographic data, right?
Exactly.
Yeah, that's if you did not change anything in the scale, then you don't have to revalidate it. The socio-demographic, there is no validation for the socio-demographic or the background information that you would like to collect. For sure, the socio-demographic data needed for studies are different. For example, if I may need the pulse and temperature in my study. However, you don't need the the history of whether this patient have a diabetes or hypertension in your study. So this is considered a background or socio-demographic question. So if you will change them, this will not change anything in the validated scale. The scale, talking about the scale, yes, if you change something on the scale, you have to revalidate.
And you could like combine like more than one questionnaire, like combine different parts.
You can combine more than one scale in one single study, yes.
Perfect, thank you.
No worries. Okay, Waad, what do you think? Shall we take more questions or?
It's based on your opinion, doctor.
Yeah.
Feel free.
Okay. Next, please.
Assalamu alaikum.
Assalam.
Doctor, do you recommend any tools for randomization for survey?
I didn't get it. What do you mean?
Like for distribution, accepted tools. When we talk like about public awareness, for example, and we want to distribute a survey, but with randomized distribution, how can we get this?
Well, you're talking about the sample.
Yeah.
All right. So surveys usually, well, you can't reach the randomization. I mean, there are two different types of samples in research. We have what we call probability sampling technique and nano-probability sampling technique. And in a probability sampling techniques, we have a different subtypes, like simple random sampling technique, stratified sampling technique. We have what we call it a systematic sampling technique, and stratified systematic and simple random sampling technique. And in under the probability the nano-probability sampling technique, we have what we call it a convenience sampling technique, a purposive sampling technique, and so on. In questionnaires, mainly it's a convenience sampling technique. Convenience, what does convenience mean? It's a very easy to get. So it's very hard to reach to, to apply a random in scales or a randomization sampling techniques, or to follow a random sampling techniques in scales. It can be, but it might be very, very hard.
Okay, thank you, Doctor.
No worries. All right, so Mishal, yeah, you may talk, yeah, Mishal. Mishal or Mishal, I don't know. Hello, Mishal or Mishal. You can talk. You can ask your question, please. Hello? Okay. All right, so Rinad ala Mishal or Mishal or Michelle, or I don't know. Hanan. Okay, Hanan, you may talk, please.
Yes, hello. First of all, thank you for interesting lecture. Doctor, I'm going to collect data from concerned patient outcome, especially falls and ulcer pressure, hospital-acquired ulcer pressure. So this tool, do I need for reliability and validity test for the tool?
What sort of tool is it?
Actually, it is it's just a tool for collect data from patient reports as an incidence of falls or ulcer pressure.
Well, I don't think we call this tool, we call it a data collection sheet. Did you prepare it yourself?
Until now, in the process, I didn't prepare, but I'm planning to prepare one.
All right.
So
for example,
it is like as a questionnaire, we need valid and reliability test. Or
what sort of data are you going to collect? Is it age, gender, pressure, ulcer, for example, degree, and what was?
Yes, the degree, the place, and when it started.
Right, and what was the cause of the pressure ulcer? The
I'm not concerned about the cause. I'm concerned because the incidents.
But to me, this is not a tool. This is a data collection sheet. You will collect it for your own study. So this is not a tool that needs to be reliable and valid. Okay.
So I don't need to rely for testing reliability or validity.
Reliability and validity for scales only. So we have to differentiate between scales and other tools.
Yes, because I'm going to measure the workload and the incidence for the ulcer among healthcare providers. Thank you so much. Thank you.
That's only a data collection sheet. Well, I think we shall stop here, and I'll continue with the types of the data. Thank you very much. Okay. Okay, so all right, so there are different types of data. We have what we call it quantitative data, or numerical data, another name of it. And we have a qualitative data or categorical data. Well, in a quantitative data, there are two different types. We have what's called continuous and discrete. متصلة ومنفصلة. So, in continuous, for example, it may have fractions. Discrete, it doesn't have fractions. For example, someone may come and ask me how many family members in your family, Abbas. My answer is 5. Okay, so I can't say 5.5, for example. So that's called a discrete, a numerical, a quantitative data. Well, age, weight, it may have fractions. All right, so for example, temperature might be 36.5 or 36.7. It may have a fraction, so that's continuous. That's considered continuous in numerical data. And qualitative, we have different types as well, ordinal and nominal. Well, ordinal, for example, cancer stage. We have 4 cancer stages: stage number 1, stage 2, stage 3, and stage 4. If I'll ask a question, what's your cancer stage? If I ask a patient a question, what's the cancer stage? I can't give an answers or choices. Stage 1, then I jump to stage 3, and then stage 4, and then I go back to stage 2. No, they have to be in an order: stage 1, 2, 3, 4. So this is called a ordinal qualitative data. Nominal, it doesn't have to be in an order. Do you smoke? Yes, no. Or no, yes. Gender, male, female, or female, male. It doesn't really matter, you know, or they don't have to be in an order. So in general, there are 2 different types of data. We have a quantitative or a numerical, another name, and we have a qualitative or categorical data. Quantitative, we have 2 different subtypes, continuous and also discrete. And in categorical or qualitative data, we have 2 different subtypes as well. We have ordinal and nominal. Okay. All right. And a qualitative, it deals with description, for example, color, gender, male, female, smell, taste, appearance, beauty, and so on. That's a qualitative data. And a quantitative, it deals with numbers, you know, something that can be measured: temperature, pulse, systolic blood pressure, diastolic blood pressure, sound level, cost, age, and so on. All right, so these are, it's a very, very important to differentiate between the different types of data. Well, this will take us into another issue, which is the data measurement levels. You know, nominal, for example, or ordinal and ratio interval data. You know, ordinal, ranking order categories, mid-level, lower level, mid-level, higher level, and so on. So it's an order. A nominal, codes, ID number, category names, for example, and ratio or interval data. That's a complete analysis. It's a very, very important to differentiate between the types of the data in order to apply the right statistical methods or the right statistical test to the correct data. I'll explain this later on. This will take us into a different, also a issue, which is called the variables. Variables, what do we call it? Why do we call it variable? Variable is, it varies between one to another. Okay, it may change. For example, my age is different than yours, so age is a variable. My gender, I'm a male, and Abrar is a female, right? So we are different. So gender is another variable. All right, so variable, as we observe, are characteristics. We find that takes on a different values in different persons who we label. So for example, blood pressure is a variable, heart rate is a variable, height, gender, weight, age, for example, are variables. And we have quantitative variables and qualitative variables as well. The quantitative variable has values that are fundamentally numbers. And a qualitative, the variable is categories. All right, so in quantitative variables, for example, the height, the weight, the time, number of children in a family, it's all, I mean, numbers. While in a qualitative variable, it's a categorical. Gender, male, female, another color, for example, hair color, skin color, blood group, AB, O, that's the cause of death, for example. That's a categorical data, categorical qualitative variables. And then we have different types of qualitative variables. For example, a nominal doesn't have to be in an order. For example, gender, male, female, or female, male. Do you smoke? No, yes, or yes, no. So it's a nominal. Nominal have data have no order, that thus only gives names or labels or to various categories. The lowest measurement scale is the nominal scale. It consists of naming observation or classifying them into various mutually exclusive categories. So it's a categorical, qualitative variables that doesn't have to be in an order. That's a nominal. An ordinal, it has to be an order. A qualitative variables. So whenever observations are not only different from category, you know, for example, I'll give an example of an ordinal scale, like I've just mentioned that the cancer stage number 1, stage number 2, stage number 3, and stage number 4. Intelligence of children, above average, average, or below average, they have to be in an order. We either start from the bottom up or up to bottom. All right, so we may start from below average, average, above average, or above average, average, below average. So numbers can be assigned to ordinal data. Everything, I mean, qualitative, and I will teach you how to do coding for qualitative data as well. All right, so measurement and data quality. What time is it? Okay, we have 5 minutes. Measurement and data quality. We have 5 minutes until break. Measurement and data quality. So, well, a measurement is the assignment of a numbers to represent the amount of an attribute present in an object or person using specific rules. So we have to give a measurement that represents the amount of an attribute. All right, so why do we do this? To remove guesswork and provide a precise information and to have an accurate, and less fake than words, to have an accurate data collected. So level of measurements, we have, as I've mentioned earlier, nominal, ordinal, interval, and ratio. Nominal in measurement, assigning numbers to classify characteristics into categories. All right, for example, I may give gender male 1 and female 2. Okay, ordinal, or I vice versa, for example, male 2 and female 1. Ordinal, ranking objects based on their relative standing. For example, stage number 1, I'll give it 1. Stage number 2 of cancer, I'll give it 2. Stage number 3, 3, and stage number 4, 4. That's ordinal. Interval objects ordered on a scale that has equal distances between points on the scale. So, for example, in scales, we have 3 or let's say we have 5-point scales. Strongly disagree, disagree, neutral, agree, and strongly agree. So strongly disagree will be 1, or strongly disagree will be 1, okay? And then agree, disagree will be 2, neutral will be 3, agree will be 4, and strongly agree will be 5. So there is an interval between, order on the scale, okay, and equal distances between the points, all right? And the ratio equal distances between score units, there is a rational, meaningful 0. So it's a rating scale. I think we have example later on. I'll show it to you. A variable level of measurement determines within what mathematical operation can be performed in a statistical analysis. All right, so a psychometric, I'll try to only cover those and then we will have a break. Psychometric assessment. A psychometric assessment is a statistical test or statistical assessment of the tool to check, or a criteria to assess the reliability and the validity of the tool to be used for data collection. Reliability, what does reliability mean? Is the consistency and accuracy which an instrument measure the target attribute. Yani, does this instrument measure what it's supposed to measure? Okay, so reliability coefficient can range from 0 to 1. The closer to 1, the more acceptable is that tool. The closer to 0, that's unsatisfactory item or tool. So usually above 0.70, that's satisfactory. Less than 0.70, that's unsatisfactory. Okay, that's the reliability. And there is a test called the Cronbach Alpha, where it studies the interconsistency, the interrelationship between the items themselves, all right? And it gives you a score from 1 to 0. That's a reliability, is the consistency and accuracy of the instrument. And then we have a validity, the degree to which an instrument measures what is supposed to measure. That's a validity. And then there are different aspects of validity. There is what we call face validity, content validity, criterion related validity, and construct validity. All right. Okay, so that's the validity. Now, I'll just open this for discussion. I'll ask a number of questions, then we can go for a break, 10 minutes, and then we continue. Okay. Okay. So, so far I've talked about the data collection methods and the types of the data. Can I ask those questions, please? Say, for example, we have a okay. Okay, so an admitting diagnosis of patients admitted to the mental health clinic, for example, weight of a baby's born in a hospital during a year. The weight, what type of data is it? Can anyone answer it, please? Okay, yeah. Our hands. Okay, so weight, what type of data is it? Hello?
They're asking you, doctor, in the chat box. You can see their answers.
All right, so it's a quantitative. All right, good. What type of quantitative is it? Is it a numeric? Is it discrete or continuous? Continuous, mumtaz. All right, and then we have the other question is, mumtaz, great. The other question is, gender of babies born in a hospital during a year. Qualitative, nominal, all right, or continue. Qualitative, is it nominal or ordinal? Nominal. All right, cool, good, great. Now, the other slide is sometimes very good. Can you read the other question, because I'm not able to read to follow both. Wa'ad, can you read the other question, please?
Okay. For discussion D, range of motion of elbow joints of students enrolled in a university health science.
So range of motion, is it quantitative or qualitative? And it's a quantitative. What type of quantitative, please? Ordinal, very good, great. Second question, please. So it's an ordinal, yes, range is an ordinal quantitative data. Very nice. E, please, Wa'ad.
Sure. Under arm temperature of a day-old infants born in a hospital.
So arm temperature, under arm temperature, is it quantitative or qualitative? Quantitative. There is nothing called the quantitative nominal, by the way. Quantitative, continuous. Great, okay. Now, one more question and then we'll take a break for like 10 minutes. Age, is it quantitative or qualitative? What's your age, for example? If I ask a question, what is your age? Is it quantitative or qualitative? Is it numerical or categorical? Numerical. What is your age? Okay, my age is 40 years old. It's a numerical. If it is a numerical, that means it's a quantitative. Now, if it is a numerical, is it discrete or continuous? All right. So it's discrete. It's continuous. Sorry. Okay. So it's a numerical, continuous data. Now, if I said, what is your age? And I've given you choices. 18 to 25, 26 to 30, 31 to 35, 36 to 40, and above 40. Is that qualitative or quantitative? It's an ordinal, what? Ordinal qualitative. Very good, very good. All right, so we'll have break. We'll have break, Wa'ad.
Yes, doctor. Thank you, Dr. Abbas, and thank you to all of the participants who joined us so far. Our break will start now for 10 minutes, and we will be back at 8:45 p.m. Take a deep breath, refresh your mind, and we will all see you soon.
Thank you very much.